Hello and welcome everyone. My name is Chad Sievers and I'm the project manager for Arkansas Building Effective Services for Trauma, and just wanted to welcome you to today's webinar, The Story Behind the Cycle, with Dr. Suffman John. And so before I turn it over to her, I just want to kind of tell you briefly about our program and then just do some housekeeping announcements. So Arkansas Building Effective Services for Trauma is a state-funded program at the UAMS Psychiatric Research Institute, and our aim is to improve mental health services for children who have experienced trauma from events such as abuse, natural disasters, and even family separation. We work really closely with our state child advocacy centers and other providers in the state to build a trauma-informed mental health system. We're probably best known for providing training to mental health professionals and treatments that are effective with helping children recover from trauma. And so that's just a little brief overview about our program. Just a few housekeeping announcements. We encourage questions during the presentation, and you can, to type in a question, use the question feature, which is on the right side of your screen. And if you'd like to earn 1 CEU, just be sure to stick around to the very end. We have a code that's given, and I'll give more instructions when we get to that point. We are recording this webinar and we'll upload it to our YouTube channel. We also have other previous webinars that are there. We only award CEUs for attending live webinars. So, and if this topic or other training that we do is of interest to you, you can like us on Facebook. We frequently post there. It's probably the best way to kind of keep in touch with what we're up to training-wise. So, so I'm going to turn things over to my boss and our program's co-director, Suffman John.
Thank you, Chad. Welcome, everybody. I am just getting over a little bit of what I'm hoping is seasonal allergies, so you'll have to excuse the little catch in my voice. I'm well equipped with a water bottle, so hopefully it won't interrupt what we're doing. Also, I am talking with you guys from my office at the UAMS Child Study Center. So just so you know, if you hear any kids screaming in the background, that's why. So I am delighted to talk with y'all about a topic that means a lot to me. I think oftentimes I'm someone who is one of our state trainers in child-parent psychotherapy, which is an evidence-based intervention for children 0 to 5. And a lot of times I think earlier in my work, and the questions I continue to get when I present on this topic in our communities really focuses on how can we stop this cycle? How can we prevent families from having to bear this historical trauma through their generations? And so what I'm hoping that I can do for y'all today is provide you with some of my input on this and some of the input that is within the literature to help us think through this collectively as a mental health community. So as Chad mentioned, Chad, hold on. Oh, there we go. Perfect. Okay. It wasn't letting me forward my slides for a second. So Chad mentioned Arkansas Building Effective Services for Trauma, the ARBEST program. And so I won't go into too much detail here other than to let you know we hope to be a fantastic resource for y'all, not only in your initial training of evidence-based treatments, but also in your training of understanding more about trauma and the ways that we can advocate for these vulnerable children. So what we're going to do is spend some time focusing on the impact of trauma on young children and understanding really how what happens to us when we're younger can persist into adulthood. Let you know how parenting can be impacted by experiencing trauma, and then discover how you, as a childhood professional or someone who engages with young children, how do we really promote resiliency in this age group? What can we do to contribute? So before we get started with how trauma impacts children, it's helpful for us to all have a shared definition of what trauma is. So trauma refers to life experiences that are scary, dangerous, or violent. They can happen to ourselves or happen to someone close to us. And here are some just kind of common traumas. I think a lot of times when people think of trauma, they think of maltreatment, things like abuse, neglect. But they don't always think about other types of trauma, like natural disasters, serious accidents like car accidents or fires, or what's really relevant for a lot of the kids that we work with within child welfare is separation from parents or caregivers within entry into the foster care system. So trauma can occur once or more than once, and I probably don't have to let y'all know that it's much more common for it to occur more than once. And trauma often, unfortunately, leads to other traumas. So if we take, for example, a kid who, let's say, is removed from the care of his mom and dad because they were using substances and not able to care for his basic needs. So we may have neglect, then this child moves into the foster care system, so we might have separation from parents and siblings. Then maybe because his behavior is showing us that he's really struggling with this transition, he might have to bounce around to a few different homes, and that's more separations and more transitions. And so as you can see, really trauma starts to pile up and build up quite quickly for children. And this is really reflected in what we see across our state. So within Arkansas, these are numbers from 2017, though the rates are not much different now. Within Arkansas, 70% of the maltreatment that children experience is in the form of neglect. What you'll notice is those percentages in the state add up to more than 100 because that's accounting for children who experience more than one type of maltreatment. Some statistics that I think are troubling and really help us to understand the call to action we have here in Arkansas. We are only second to Mississippi in how many children die of maltreatment here in our state. We're number 2 of 50. And unfortunately, our victimization rate isn't budging a whole lot. So our child victim rate of 13.2 tends to stay around that area. Suggesting to us that although we might be treating childhood trauma better in our state, we are a ways to go in preventing it from occurring in the first place. And when we think about who bears the brunt of the trauma that we see in our state and nationally, it is young children. So children 0 to 5 make up 50% of maltreatment in the whole age range from children 0 to 18. And if we delve in even closer to our youngest children, by age 4, more than 25% of all children will experience a traumatic event. If you think about that in a classroom of pre-K of 20 children, 5 of them will have experienced a traumatic event by the time they hit pre-K 4. Those numbers are astounding. 79 out of those 1,000 children who experience victimization are in the age group of 0 to 5. Victimization is highest for your first year of life. That's actually the most vulnerable year in your entire life you have to experiencing maltreatment is your first year of life. And unfortunately, you're also most likely to die from the maltreatment you experience in children who are young. And so hopefully what this does for you is paint a picture of why focusing on young children within the story of trauma is so incredibly important. And we'll talk a little bit about now the impact of trauma on young children. So trauma impacts children in a variety of ways. One of the ones that's most commonly talked about is the idea of attachment. So attachment is a word that we use to describe the relationship that children have with their caregivers. I kind of joke around now that attachment seems to be like a really buzzy word in our mental health community that's been taken on to mean a whole lot of different things. What I really want you to focus on is attachment from a true developmental perspective refers to how children behave when they are frightened. Do they seek safety from caregivers, and do they accept that safety or that comfort when it is provided? It's not how extroverted kids are. It's not how quote unquote manipulative or naughty or how much they misbehave. It's not hoarding. It's not any of the behaviors that are often characterized under attachment. Children's attachment to caregivers is a dyadic process. What that means is it relies on interactions between both the child and the caregiver, and it's built over the course of thousands of moments of one-on-one contact between children and caregivers. It's important to note that a child's attachment to a caregiver is relationship specific. So we often see children have a different quality of their attachment to different parents or caregivers in their life. And why attachment is important is that how early caregiving relationships work influence what children come to expect from relationships in their lives. And so if you think about it, back to when you were a kid, I bet you formed ideas of relationships, of friendships, and how the world works through some of those experiences you had as a child. Trauma impacts the way your body responds. So we often see increased physical complaints like headaches or stomach aches in children. We see difficulties with attaining developmental milestones like walking or talking, and sometimes even things they were doing before, they've regressed and are no longer showing us they're capable of doing developmentally. Trauma often disrupts routines, things like sleeping or eating. And this is really problematic and causes a lot of impairment. So I think any of us who have parented young children can attest to the idea that how they sleep and how they eat and how they use the potty are really incredibly important things to our own sanity as parents. Children who experience trauma could become extra sensitive to being touched or held by others. And finally, their immune systems are actually dampened by chronic stress exposure, making it difficult to fight illness. So I want you to think about a time in your life in which you've been really, really stressed out. Oftentimes people will say, of course, and now I get sick on top of all the other things that are happening at work. That's not a coincidence. So what we know is that chronic stress often impairs our body's ability to fight illness. And we see that a lot in young children. Trauma in young childhood also impacts the way that children are able to control their feelings. Children might be more fussy, hyperactive, or irritable. They might be more sad or worried, but we also don't want to forget about the children who have less emotions than we would expect. So if you think about it, remember, we're talking about infants, toddlers, and preschoolers here. We are expecting them to show us the breadth of experiences and emotions that people can have. Toddler and preschool years are the years of really strong emotions, whether they're really strong negative or really strong positive emotions. I often wish that someone could or something could make me as excited as bubbles make young children, right? So we expect them to have these huge emotional responses to things. That's normal development. But unfortunately, for some of our children, they are dampened down such that they don't show us the emotions that we would expect. It's important to pay attention to these kids too. Often these kids are missed because they're not causing problems to parents or daycare teachers. And so we want to be sure that we're always looking at both over and under responders. This is one of my favorite quotes about childhood behavior. That behavior is I have something to say. So many times young children do not have the words that they need to help us understand why they're acting the way they do. I think it's so common for us as adults to ask children, why did you do that? And when you think about their language development, that's a really tough question for kids to answer in any mood that they're in. Children who have experienced trauma often have troubles controlling their behaviors. This is called regulation. So they have really a strong difficulty in regulating both their feelings and their behaviors. The kids we often see coming to our clinic are those that have too much of these negative behaviors, like temper tantrums or crying spells, having a really short fuse. I often describe trauma to people as experiencing trauma is like being a pot of boiling water with the lid on. These kids are constantly on simmer, and it's very difficult for things in their environment to trigger an overflow or a boil over response. And what we technically call that, of course, in mental health is the idea of alterations in arousal and reactivity, right? That criteria within PTSD. But how that looks in a young child is a lot of meltdowns. But we don't want to, again, forget the kids who don't have a lot of behavior problems. I am equally as worried about the 2-year-old who can't comply with anything than I am about the 2-year-old who complies with everything. Because 2-year-olds shouldn't, right? So we know in development, they should be asserting autonomy. We should see pushback to caregivers. That's a normal part of development. So again, priming our radar as mental health clinicians to recognize both the under and the over is really important. Trauma impacts the way our brains organize. And so trauma in young childhood can be incredibly impactful for brain development. This is a statistic that can shock a lot of people. 90% of a child's brain development happens before they turn 5 years old. So if we're thinking about where can we get the most bang for our buck in changing long-term outcomes of experiencing trauma, it's in these first 5 years when we still have a lot of plasticity or movability or adjustments that our brains are able to do to help buffer some of the negative impacts that are potentially happening after kids experience trauma. One of the core places we see kids show the impacts of trauma on their brain is something called executive functioning skills. This is things like planning, reasoning, organizing, paying attention. Those types of skills are just coming online in preschoolers anyway. So if you know typical preschoolers, those are not their strong suits anyway. But for kids who have experienced trauma, they can be a lot worse. So we may see kids who are more distracted easily, who have trouble sitting still. They may be more disorganized. And oftentimes that looks like ADHD to folks. So it's not saying that kids can't have ADHD and trauma both. In fact, many do. It's simply to say that either trauma could make those ADHD symptoms worse, or trauma symptoms could mimic and look like ADHD when perhaps those are really more due to those lacking executive functioning skills in young children. So this is a really small slide, but the important thing for you to see is that right here at age 5 is where we see a really steep incline from 0 to 5. You'll see that growth and that hill is growing really strongly before the age of 5 and how these skills develop. And then you'll start to see it kind of plateaus, maybe even starts to go downhill. So for some of us who are in our 30s and 40s and 50s, we might start noticing that we're not as strong in executive functioning as we were before. Don't worry, that's actually normal decline in how executive functioning skills work. But if we imagine young kids need executive functioning in order to kind of comply with our instructions. So if I told a kid, pick up your shoes, put them by the door, grab your backpack, and come sit at the table, they not only have to memorize those, they also have to put them in the order of the way that they would work, and they have to have enough focus to remember all 4 and enact all 4. That takes a lot of executive functioning. And so we want to be thoughtful of how we're framing things to young kids who have experienced trauma, because that might be just more challenging for them than it even is for the average preschooler. And that box right there kind of highlights for you that steep incline in children before the age of 6. Trauma also impacts the way we think about ourselves. For many children, they may feel ashamed or embarrassed or guilty for what has happened. They may show us low self-esteem or feelings of being unsafe or unloved. There's this magical thing about early childhood called egocentrism. It's the fancy word for everything that happens revolves around me. It's because of me. We actually see this in young children, also in teenagers. But in young children, the tricky part of the idea that everything revolves around me means that bad things that happen to you revolve around you too. And so we often see distortions of children blaming themselves for things they couldn't possibly have been responsible for. And part of that is due to where they are cognitively in that stage of egocentrism. And then finally, trauma really impacts the way children think about the world and how safe the world is. If you imagine a young child when they enter into a new room, they're often checking back and looking at their caregivers to understand what is safe, who is safe here, what can I do, what's okay to do, what's not okay to do. This natural developmental process of checking in with caregivers is often undermined by unsafe early attachments. Just think about it. If you had a mountain guide that was helping you learn mountain climbing, but every time something was unsafe, only some of the time they let you know that in advance, you would start trusting that mountain guide less and less. You might not ask him or her about how safe it is because they have not shown themselves to be consistent in helping you to be safe. This is really similar for our young kids. If caregivers are not consistently giving children reliable ideas of safety, it would only make sense that they would look to caregivers less and less to determine the safety of an environment. So before we talk and kind of move forward from just how early childhood impacts children, early trauma impacts children during childhood, I want to see, are there any questions that have come through chat or any questions that anybody has before we kind of move into the impact that early childhood trauma has on adulthood?
None have come in yet, so I think we're okay to move ahead.
Wonderful. Okay. So what we're going to do now is focus a little bit of our attention, this next third of our presentation, on how does trauma really impact parenting and adults. Let's start the conversation with some statistics about what trauma prevalence looks like. So here's Arkansas. Please find your county. So my county is Pulaski County. And if you look here, that means 15.5% of adults in our county have experienced at least 4 or more adverse childhood experiences. If you haven't heard of the term ACEs yet, or adverse child experiences, these are kind of events that could be stressful. Things like abuse, growing up in a home with a caregiver who has a significant mental health disorder. While adverse childhood experiences give us some of the picture of what trauma exposure looks like, they don't include actually a lot of different types of trauma that we know can happen. So if you have 4 or more adverse childhood experiences, who knows how many other types of trauma you might have that aren't even captured by ACEs statistics. Here's why that prevalence rate is so troubling. Okay. We know that experiencing early childhood trauma has an additive effect. What that means is the more trauma you experience, the higher at risk you are for negative health outcomes. And when we first looked at ACEs, I think the community was like, yeah, we can understand how people who experience trauma in their childhood may be likely more depressed or may use substances more often. Yeah, they might struggle with like those mental health things because of trauma. But I think people didn't fully appreciate how much mental health is tied to physical health, and how much experiencing early childhood or childhood trauma impacts and puts you at risk for things like diabetes, heart disease, cancer, COPD, missed work. And when we started kind of building up the toll that trauma can take on our bodies, I think we come to the conclusion that childhood trauma is a significant public health crisis. And so when we think about ways to help adults be healthier, talking about preventing trauma should be an important part of that conversation. So not only does this have impacts in the short term, it also has impacts in the long term. What we see for people who experience trauma in childhood is early onset of puberty, major illnesses, risk factors like teen pregnancy and teen motherhood, cognitive deficits like having impaired abilities to think and reason through things, of course having an increased risk in mental health difficulties like PTSD, depression, aggression, also in substance use like drug and alcohol abuse, and finally, and I think potentially most sad and most relevant for our conversation today, is re-victimization. So experiencing trauma in childhood puts people at a greater risk for experiencing trauma in adulthood as well. And as we talk about the impact of trauma on parenting, I want y'all to be thoughtful of why is it that the impacts we have as children could put us at greater risk when we are adults. So let's talk about the impact of complex trauma on parenting. So this is a soapbox for me, if you haven't already been able to tell. But here's what I want to hopefully help imprint on you as we're going through these slides. I think as a community of mental health providers, and also as a community in general, we tend to have a lot of grace and understanding for the impact of trauma on children. When children present with really troubling behaviors and emotions and they have experienced trauma, a lot of us are able to go, yeah, I mean, what did you expect? They've been through something challenging and terrible. But for some reason, we lose that grace in adults. Suddenly, when you turn 18 and you're an adult, we lose our compassion a lot of ways in thinking about how trauma has experienced adults. And instead, it's much more tempting for us to start having a much more punitive view of adults than we do of children who are showing us the impact of their trauma. So I want us to think together on how trauma can impact parents. Becoming a parent represents a really important milestone in adult development. Certainly everyone does not become a parent, so it's not a necessary part of being an adult. But I think most parents will tell you being an adult is one of the most life-changing and impactful things that has happened to them in their life. Thoughts of becoming a parent often trigger thoughts of our own childhood and our own parents. I will tell you, I'm the parent to two young children. I have a 4-year-old and an almost 2-year-old. And I think of my own parents and my own childhood so often when I'm parenting my children. And for some of us, those thoughts and feelings are positive ones. For some of us, those thoughts and memories are negative. For many of us, they're both. So if you think about adults who have experienced trauma as children, pregnancy and parenting often serves as trauma triggers for early life adversity. The thing I want to make sure you realize is it's not only the negative parenting experiences that remind us of the negative. So for example, when my kid is yelling and temper tantruming and I start to get really frustrated, perhaps that reminds me of moments in my childhood where my grown-ups yelled at me instead of taking care of me. Okay, that's maybe an easy thing to understand. But I also want you to realize that positive things, like funny moments I share with my son laughing over ice cream, might remind me of how nobody did that for me, and I didn't have that growing up. So even positive interactions with our children can trigger trauma that we've experienced during our own childhood. Parenting comes naturally, but it often comes in the way we are parented. It's difficult to give what we haven't had. So is that to say that someone who has experienced early childhood trauma is doomed to be a poor parent? Of course not. What this is saying is in moments where we are stressed, we often default to what we know best. And what we know best has a lot to do with what we have experienced. And unfortunately, parenting is full of stressors. And so individuals who have been through early life trauma already have a heightened stress response system. And on top of it, just routine daily parenting is really stressful and difficult, no matter who your kid is and no matter what support you have. Finally, parenting requires a lot of executive functioning skills that I described earlier. Things like thinking, planning, reasoning. These are often underdeveloped in individuals who have experienced early trauma. And then finally, remember that child trauma often puts us at risk for adult trauma. So we're not only talking about the trauma that these parents experienced during childhood, we're also talking about the trauma that they might have continued to experience as adults. Okay? So adults really may find themselves in relationships with others that contribute to their own trauma, and also, unfortunately, increase the likelihood that their children will experience trauma. So this slide should look fairly familiar to you because we just talked about these outcomes of traumatic experiences in children. But what I want us to do now is think through together about how this might impact adults. I'm going to ask you a lot of rhetorical questions in this part of the presentation. I want you to sit and think with those questions. It's not necessary to answer them per se, but I do want to hopefully give you something to think on as we move through this part of the presentation. Trauma impacts the parent-child relationship. Either member of the dyad meaning a caregiver or a child, can develop new ways of thinking or feeling based on trauma experiences. Okay? Parents and children often serve as traumatic reminders for one another. A parent screaming can remind a child of their biological parent or their dad or their stepdad or stepmom, someone who would yell at them a lot. And in that way, we can serve to trigger children with our own behavior as adults. But also, adults who experienced a lot of crying and rage as children often will be triggered by our responses as adults seeing those kids. So it's not just that kids are triggered, it's often that adults are triggered within interactions they have with children. And in many ways, one of the common ways to see this is in the way that dyads are able to navigate emotional situations. So when the emotions get hot and the temperature goes up, how do caregivers and children navigate that process? That's often impaired in children and adults who have experienced trauma. Okay, so remember I told you that trauma impacts the way your body responds to illness and to stress. So parents may experience increased physical complaints like headaches or stomach aches. They are at a greater risk for inflammatory diseases and pain conditions like fibromyalgia, migraine, that often lead to high levels of prescribed medications. So I want you to sit and imagine, how easy is it for you to parent when you have the flu? I will tell you, if someone came into my home and watched me parent when I have the flu, I would not want to be judged by that. That is not my shining moment. And we think about adults who have experienced trauma as children, their bodies have often paid a toll for that trauma. And we want to be thoughtful about, are we being reasonable in our judgments and our suggestions, taking into account what parents' bodies are experiencing? But let's keep going. Remember I told you trauma impacts the way that we feel and the way that we control our emotions. How you learn to regulate or control your emotions is actually a really predictable developmental process. So think about a crying baby. When a baby cries, we pick them up and we put them up against our hearts. And this can be, sorry guys, you can probably hear my phone. I'm going to put us on mute. Okay, perfect. So we often learn to regulate through other people. So remember that crying infant, we pick them up and put them close to our heart as adults because that co-regulation helps to build up children's ability to regulate their emotions. We actually don't expect kids to be able to consistently regulate their emotions till at least 4 or 5 years old. And so kids really rely on adults to help them learn how to make sense of their emotional experiences. Now imagine these adults who have not experienced that as children. They didn't have an adult who helped them learn how to control their emotions. I mean, how many of the parents that come into your office with their kids have trouble controlling their emotions? This is a really common thing that we work with. So I want you to think about, how easy is it for me to parent on my moodiest day? On the hardest emotional day for me, how easy would it be for me to be a stellar parent? It also controls our behavior because when our emotions are out of whack, it impacts the way that we behave. Remember that adults who've experienced trauma often lacked role models of normative or positive parenting in their lives. And we know that their bodies, remember those alterations in arousal and reactivity, that's a core symptom of PTSD. So many of our parents are operating with increased agitation and irritability. How easy is it for you to parent when your child is having a meltdown and you're running late for work? That feeling of dysregulation, how easy is it for you to remain calm and consistent and helpful when you're experiencing that level of strain? We also know that trauma impacts the way you think about yourself. Many adults that we work with have a lot of sense of responsibility and shame and embarrassment related to the trauma their children have experienced. And then these thoughts of I'm terrible are often reinforced when we interact with other people. So a parent who says, gosh, I'm a terrible person to interact with, and then in interactions with other adults, those don't go well either, that only serves to make sure they remember, yeah, see, I told you, I really am bad. I really am shameful and embarrassing and a bad person. And I say this all the time, and I find it true of myself as well as a parent. Nothing can make me feel as incompetent as not being able to manage my children's behavior. When I'm like out in public and my kids are having a meltdown, I feel like so useless, like so incompetent. And imagine how easy it would be for you to parent if you chronically felt incompetent and guilty and embarrassed. That would make it really challenging to deliberately make parenting choices that are positive. So remember, I told you about executive functioning, that planning and reasoning. What I've delineated for you is the mark here, that is age 18. So what you'll notice is if you don't develop those skills before 18, there's a very little growth that then happens to the right of that red line, okay? And so what we have to be thoughtful about is our parents, if they didn't develop those skills as high as we would like them to be before 18, we need to make accommodations in the way that we're working with them to account for that. So how many parents do we prescribe them a whole list of things to do and they come back and they say, I didn't do it. I didn't do any of it. I didn't remember. Shoot, I forgot to bring my homework back, right? If it was a kid, we'd put in all sorts of systems because we'd understand that their trauma impacted their ability to work through things. I just want you to have that same grace and problem solving when it comes to the adults that you have. Because remember, many of aspects of parents rely on intact executive functioning. Did I remember to give my kid the medicine the way I'm supposed to? How do I juggle when many of my kids need different things? So I want you to ask yourself, how easy would it be for you to parent on days when you felt scattered and overwhelmed? How easy would it be for you to make those choices that we would prescribe as clinicians for you on days where you're feeling that way? And then finally, many people who experience trauma experience dissociative symptoms. That idea that it's hard for me to stay present and in my body in this moment. Dissociation is often developed as a protective mechanism during abuse. Imagine during an episode of sexual abuse, it would probably be really important for your well-being and survival not to be connected to your body's experiences in that moment. But once you're out of abusive things, it's often hard to retrain your body not to disconnect from itself. But that's hard when you're parenting. As parents, we want our parents, or as clinicians, we often want our parents to stay connected to their kids, to stay present in the moment that they're interacting. And that's a tall order for people who have experienced trauma. So I ask you, how easy is it for you to parent if you're not present or engaged in the moment? Let's say you're writing a work email. How easy would it be for you to write a work email and attend to your child at the same time? That would be really challenging. And a lot of our parents are struggling with that divided attention and staying present in interactions because of executive functioning and dissociative features. Okay, so what I want to do is pause here again to ask if y'all have any questions, because now what we've done is go through the prevalence of trauma and go through how does early childhood trauma impact us as kids, impact us as adults, and impact us as parents. Does anybody have any questions about that before we spend the rest of our time together focusing on, so this is a bleak picture, what can we actually do about it to be helpful to the families that we serve?
Okay, yeah, so just a reminder, if you have a question, to type those in. Jennifer, I'm reading your question. If you could just maybe give a little bit more context about that, or some more details, I'll try to answer that.
Okay, so I'll keep going for now, and Chad, feel free to interrupt me if anything comes through.
Yep.
Okay, so now the age-old question of what can we do about this cycle, right? About children being abused and growing up and then being involved in maltreatment as adults with their own children, and those children then growing up, right? Oftentimes it's really disheartening as a clinician to see, man, that trauma history that parent told me, that's the exact same trauma history their kid has. And I want to figure out a way to stop this from occurring. So I'm going to tell you a little bit about what we know and changes you can start making right now in your practice that can make you more trauma informed and make you better able to stop cycles within your own family work. This is the first big one. Fostering resilience in children means investing in the adults who support them. I want to pause there. It is incredibly important for us to invest in adults who support children outside of ourselves. If we do a whole bunch of individual therapy with children, the only person they're learning to trust in those interactions is us. And there are other adults who are going to navigate and who deserve to navigate them through healing through the course of their life and their development outside of therapy. So we need to think about, how do I not only support children, but also pay real close attention to supporting adults as we're moving through the therapy work that we do together. We talk a lot about adopting a trauma-informed stance, right? That idea of it's not what's wrong with you, it's what's happened to you. But what I will say is it's not sufficient to just acknowledge what's happened to you. We need to also acknowledge how that has impacted the symptoms you have today. It's not enough to just say, we understand trauma had something to do with this. We need to then grant the benevolence or the grace that comes in interacting with people, knowing that their history is there. So I often ask clinicians who consult with me, how are you feeling in terms of grace with this parent? How easy is it for you to be gracious and to hold this parent's perspective, or to hold the perspective of trauma as you're thinking through how to intervene with these cases? Okay. We've been talking a lot today about how trauma impacts people, but it's important not to make assumptions about how it does. This is why trauma assessment is so important. Trauma is not deterministic. There are many people who will go through trauma that never develop PTSD. In fact, only about a third of people who experience trauma will go on to develop PTSD. So it's actually more common for you not to have PTSD after you experience trauma. It's important for us as clinicians to remain curious about the ways trauma has impacted someone, as opposed to just assuming that anyone with a trauma history is always going to be impacted in the ways that we think that they are. Asking about values. It is incredibly important for us as clinicians to understand what values and thoughts are contributing to the behavior that we're seeing. We often unintentionally assume that poor behavior on the part of children or parents is a reflection of poor values. They just don't care enough about their kids to do 10 minutes of special child time with them per day. They obviously don't value the relationship they have with their kids because they're not willing to invest in it. Let's be careful about those assumptions that behavior is a direct correspondence to our values. It's important to ask, because it's really difficult to intervene and effectively change something you don't understand. So let me give you a classic example. Let's say you go to your doctor and you say, man, doctor, I got to tell you, for the last month, I've been having really significant headaches. And your doctor says, great, okay, here's exactly the treatment plan we're going to do. You're going to take Advil. You're going to avoid bright lights. You're going to avoid sounds, and just starts prescribing us treatment. One, that would not feel good to us as people, because we wouldn't feel like someone took the time to get to know us. So even if at the end of the day, taking Advil would be helpful, I'm not going to trust that suggestion as much because you didn't listen to what I had to say to begin with, okay? But what if I was having headaches because I had tripped and fallen a month ago, and these are actually signs that I might have a concussion or a significant brain injury from falling? If we're so quick to prescribe an intervention without understanding the context, we might miss really important information. So as clinicians, taking even a few minutes to understand the belief system and perspective of a parent going into why they delivered an intervention before assuming it can be really helpful in fixing and getting some buy-in from your caregivers about why you're prescribing what you're prescribing. Holding ourselves and our colleagues accountable. Okay, how you feel about your families absolutely will impact the way you interact with them, whether you realize it or not. Okay, so think about just regular human interactions. If I like someone, that changes the way I interact with them. And likely, if I don't like someone, even if I try hard, that might make me overcompensate with them. That might make me shorter with them or less likely to want to engage with them. My feelings about someone matter in how I treat them. But instead of trying to avoid having feelings about people you work with, honestly, that would be impossible, and it would just blind you to the ways that your affect really is impacting interactions. Do you have access to supervision or colleague support that helps you talk through not only what you're doing in therapy, but how you're doing it and how you feel and why you're making the choices you are making in therapy? I think your access to having support often is built into when you learn a new evidence-based treatment like TFCBT or PCIT or CPP. But once that drops away, do you still have an internal mechanism that lets you talk about how you feel and how therapy is going apart from just the content of what you're doing? Here's how you could start. How do you speak about this family to colleagues? Focus on the messages they give you in return. Are we dropping the trauma lens during venting sessions? I often find this is true in my role as a consultant and a colleague, is venting has its place. It's actually a really important thing, I think, for all professionals so that they can prevent burnout. But if it only is venting and doesn't eventually transition into a conversation where we bring trauma back into the room, where we start talking about how our negative feelings are impacting the work that we're doing, that's a missed opportunity for us to be more effective as therapists. So I really encourage us to start as a trauma community, holding ourselves accountable to that trauma lens, even when we're venting to our colleagues about the things that are making our jobs more challenging. Believing in the power of relationships. So I know and I hope that y'all really firmly believe in the idea of how important a single positive relationship can be in buffering the stress of trauma. We know this to be true. The single best predictor of the outcomes of children after they experience trauma is the presence of even one adult who is safe, engaged, and predictable. Okay? But in order to believe in the power of relationships, if we truly believe that, we should really be focusing a lot of energy into building strong relationships over time. Okay? I often talk with clinicians and they become frustrated when caregivers or children are guarded within a relationship with them. It's like we know we're safe, and we're here to help you. So how come you don't immediately trust our intentions? We're not trying to hurt you. But remember, people who have been through trauma have a heightened perception of threat for those around them. Ask yourself, what am I intentionally doing to create trust in the relationship I have with someone? What we know is there are things that increase someone's trust in us. One of them is transparency. Are we genuine in the relationship we have with our clients? I cannot tell you how many people I consult with who have this whole thought process that goes through their mind as they're working with people, and they never say it out loud to the patient. Think about them from your patient or your client's perspective. They don't really understand how you then came to the thoughts that you have. They don't understand what you're thinking when you're holding it all in. So am I advising that you share all your thoughts with patients or clients? Of course not. Part of that's clinical judgment. But perhaps a practice of starting to decode yourself or be more transparent in front of a family will help them to understand why you're making the choices that you're making. And then finally, when we elicit perspectives, are we actually listening? So is this just going through the motions of, what do you think about that? Great. The minute you start talking, I'm already building my argument to help you understand why I'm right. That's not listening. That's just delayed arguing, right? So part of it is for us to figure out what are ways that we can build in genuine curiosity about why something is happening. And then finally, avoiding those disconnects or those ruptures in the relationship you have with caregivers is impossible. Conflict's actually not a bad thing in relationships. It often leads relationships to be stronger. Think about it as when you're working out a muscle, you have to tear muscle as you're working out. And then often when it rebuilds, it's stronger. This is very similar in relationships. We don't want to avoid times of conflict or confrontation with adults and children, but instead we want to focus on now, how do we repair that? So if you go through your whole therapeutic relationship, never having a misunderstanding or a moment where a client feels frustrated with you, I would venture to say you either don't know that they're feeling that way, or maybe you're not pushing your client enough for change if your whole relationship doesn't have a single moment of frustration or anxiety or annoyance with you as a therapist. One of our main jobs as a therapist is to push people to learn and try new things that they previously didn't know. And that pushing is not always comfortable. Okay? But finally, I want y'all to think about not just in your therapy room, but how do you advocate for children outside of your therapy room as a way to disrupt this legacy as they turn into adults? 80% of children now spend most of their time in non-parental childcare. What that means is we also want to advocate for children to be in high-quality childcare. That is 11,500 hours of brain building from the ages of 0 to 5. We really want our kids to be in high-quality education settings if we can help to advocate for that. And of course, I know this is beating the drum of everyone here, but evidence-based services are so incredibly important in disrupting the cycle of early childhood trauma. We know they work. They work to help kids and they work to help parents. So if you yourself are not yet trained in all the treatments you want to know, we really encourage cross-training. So looking here on this map, we now have evidence-based trained therapists in 66 of Arkansas's 75 counties. And we have approximately 80 therapists in our state who are trained in more than one evidence-based treatment between TF-CBT, CPP, and PCNT. So please follow ARBEST on Facebook, sign up for our newsletter so you're able to take advantage of training opportunities and cross-train if that's something that's interesting in you to build your toolkit.
Sapna, I lost your audio.
Oh, am I still here?
I can hear you now, yep.
Oh, perfect. Okay, sorry about that. So strange. So, you know, like I said, sign up for our Facebook, sign up for ARBEST newsletter so you can learn about training. We'll have a new CPP training starting in July, and we'll open up applications for that in just a month or two. That's that intervention for children 0 to 5. We do TFCPT trainings at least twice yearly and PCIT trainings at least once yearly. And all of that is free of charge to you as a therapist. So please take advantage of our state support in getting you best practices. Okay? And if you're not trained in one of those treatments yet, if you go to our webpage and look at a clinician list, you can sort by therapies, you can sort by counties, to be able to find providers in your area to refer to. Because of the importance of early intervention and evidence-based treatment, we don't want families to have to wait. If we have therapists available, and this can be a site for you to find therapists that are trained in those interventions in your area. Okay, so I appreciate everyone's attention so much for this hour of a webinar on a topic that I think is so important for us to think about as clinicians and challenge ourselves to hold a trauma-informed stance no matter how old someone is when they're in our offices. And so with that, Chad, I've just put some resources up here about our page, our Facebook page, my email address. Chad, are there any questions that have come through that we can talk through together as a group?
Sure, and I know you have a 1 o'clock, but for Jennifer's first question, let's see, I'm trying to get to it. So her question was about research about trauma and how the children explain their own trauma experiences. Like, you know, we were in the presentation, we see as adults, but how much do the children see their trauma? Like, how do they express their trauma? How do they tell about their trauma?
It's
like research behind that.
It's such a good question. And if we're thinking about young children, oftentimes young children express their trauma through play or through kind of thematic play. So it could be actual play of events, or it could be like themes, like monster themes, or someone always running away themes. As children get older, they're more able to use language to express to us their traumatic experiences. So that could look like a story or an art book that they draw together. I think what's important is, as a therapist, becoming trained in evidence-based treatments will help you to sharpen your lens for seeing how trauma processing works and seeing how you can facilitate trauma processing. But just realize that particularly in young children, there's a lot of evidence that they actually may not, all young children may not need to actually play out the trauma. They may instead need to just focus on strengthening the relationship and the impacts on the relationship that trauma has had. So actually for many kids who have experienced trauma, they don't need to do concrete trauma processing at all within their intervention for it to be successful.
Okay, and I know a couple of other questions came in, but I will pass those along to you, Dr. John, after the webinar, and we'll follow up with those.
Perfect. Yeah.
So thank you for your presentation today.
Thank you, everyone.
Okay, so some instructions on how to receive a CEU. So the code on the screen is 2502. Shortly after we end the webinar, I will send everyone who signed in an email, and there will be a survey link. So just go there and enter that code, and you can get a CEU. It's good for 5 days, so try to do that today or tomorrow. Enter that code if that's something you're interested in. And one person on the webinar asked about our next CPT training. CPT stands for Cognitive Processing Therapy, and it's an evidence-based treatment. It was first originally designed or intended for adults with trauma, but it does go down to teenagers. And our next CPT training will be in May, and we'll have, again, some announcements and information about that upcoming training in our March newsletter. So just be on the lookout for that. And if you have more specific questions about that training, you can email me, and I can try to answer them the best that I can. So So again, today's code is 2502. I will email you, I'll send you an email that has a survey link in it, and just enter that. So I'm going to leave this screen up for 20 seconds or so. So thank you everyone for attending today's webinar, and have a great day.